My background is that I started out thinking a lot about chronic pain from the perspective of, there we go, okay, from the perspective of education. So I spent the first decade of my career in a primary care residency program training family medicine physicians, and just found that this idea of how to approach our patients with chronic pain was really challenging, complex, and really confusing to my learners. And I came of age in the time when we really were being told that opioids were safe and effective, and we should figure out how to use them safely and effectively. So that was sort of the beginning of my training, and then I started to realize, wow, these medicines don't actually work as well as I wish they would, and I think we're causing some harm. And so it was kind of a game changer to come to understand this concept of centralized pain. So I'm going to talk a little bit about some of the big questions and barriers that I started to think about as I began to explore this, which was really, is there a way we can sort of approach all of our patients in a somewhat similar way to get to an individualized treatment plan? Because that patient comes in and there are so many factors at play that it's sometimes hard to know where to start. My clinician learners really brought to me a lot of the barriers. And so I started to think about what are those really big barriers? And then also, what responsibility do people on both sides of the equation, like me as a clinician and then my patients, who owns which pieces of this chronic pain puzzle? So this is a model that I came up with. It's not rocket science, but it just allowed me to sort of conceptualize and then offer to my learners a conceptualization of how we might come at approaching chronic pain. So I really think about it as having a few different components that lead us to the center, which is this really multifaceted treatment plan. So I'm going to go through those in a little bit of detail. And for me, what I think is sort of paramount and of the most important is really my relationship with the patient. So if I'm going to get anything else to happen in the setting of working with a patient with really complex chronic pain, it's going to be in the setting of building that doctor-patient relationship. And I started to think about this as being a little bit different than what I normally think of as a patient coming in with a problem and me telling them what to do about it. Does anyone in the room rock climb? If you've heard me give these talks, it's one of my favorite analogies, because I've really started to think about, instead of sort of me being the person climbing or doing all the work to get this patient feeling better, the patient is actually the one doing the climbing, and my job is the support role. So for people who don't rock climb, the person at the bottom who's sort of holding the rope and has you safe while you're doing the climbing is called the belayer. And I think of us as the clinicians as really the belayer. So there's two pieces to this that I think are so awesome. One is we have the patient in a supportive role, right? We're telling them, we're with you, we have you, we're gonna help you sort this out no matter what happens next. Something patients tell me an awful lot in my consultative clinic, which is in the integrative medicine space, where they come to me to get a second opinion, is that clinicians told them, I don't have anything else to offer you, I'm so sorry, kind of go back to your primary care doctor with your pain because you don't need surgery or you don't need this intervention. So I think as a primary care clinician saying to that patient, no matter what happens, I have something else to offer you, which is more conversation, more brainstorming, more strategy developing, more lifestyle management, I think is hugely important. The second piece is that as the person at the bottom of the wall, like looking up at it, you can offer advice. So for the person doing the hard work at home to change their lifestyle, to work on their chronic pain, they're the ones actually doing the climbing, but they often can't see the whole wall. So they can't see what would be next and what would be most helpful, and I think that's where our job as clinicians comes in. So I see this relationship as a partnership, and I just love this analogy to sort of visualize that. I think that we actually are a treatment as clinicians. I think that there's huge value in what we bring into the room, and so I tell my learners that use yourself, whether it's as a placebo or as an active treatment. Patients feel better when you are hopeful and positive, and they also feel better when they understand what's happening with their pain, and that's where we come in and can explain that to patients. So I just think that's hugely important. I'm going to circle to that again in a few minutes. The second thing I think is just the echo of what Dan said, which is understanding what you think is causing their pain. And I think part of this is kind of the mechanism of the physical components, but I think it's also really keeping in mind that other factors can play a huge role in their pain and suffering. So when I use the word pain, I'm actually using it really broadly in this step, which is also keeping in mind the biopsychosocial components of what could be impacting them in terms of their pain. So we've already gone through the sort of mechanistic piece of the pain, but I think for a primary care clinician, it's hugely important. These are my 2 slides I borrowed from Dan to give him credit. But I think that I use them mostly to say that I think as a primary care clinician, I have to remember that centralized pain is on this continuum, and that the majority of my patients have a mixed pain state, and making sure that I'm pulling out when that central pain mechanism is largely at play, because if I don't and I miss it, I'm not gonna be successful at really getting their pain under control or managed. So I also love this slide just because for me, that iceberg is everything I see in my primary care clinic. It's just all those diagnoses that don't have that fibromyalgia label that I really have to pull apart what is actually impacting their pain. Because every person's label isn't really gonna give me a true understanding for that particular patient, which factors are at play. So for every patient, I have to pull that apart, and that's where that relationship comes into play. I also think from a primary care perspective, this idea of the pain-prone phenotype, somebody who is at risk for developing chronic pain based on risk factors or histories of other pain conditions, is hugely important in primary care, because I think I can actually possibly impact that if I have a really good relationship with my patient and I recognize in the setting of a new pain scenario that they are at risk for the development of chronic pain. There are things I can bring to the table that can help prevent that. And so I think as primary care clinicians, we can be empowered in that way. The third step for me is to develop a goal, and I think those goals really have to be functional. It took me a long time in my practice to get away from this idea that my goal was really to decrease someone's pain, and really to get more and more into this idea that what I'm trying to do is help them develop a goal to be more functional. I know most of us are probably hopefully familiar with the difference between a functional goal and a pain score goal, but just to remind ourselves that it's really about getting them to be able to do things that they can't do because of their pain, and that has to be patient specific. I think every patient is so different that it's really in that understanding our patients to that level that helps us understand exactly what's going to be a good goal for them versus something that's unrealistic or non-accomplishable. And I think really understanding what our patient's attitude toward our pain is going to be instrumental in that. So all of this sort of circles back around to me, for me, to getting to know my patient and making sure I'm really on the same page that they are. Which leads me to the treatment plan, which I really think from a primary care perspective has to be multifaceted. And I have a few things that I've developed that are kind of my musts in terms of my treatment plan. I think your patient has to buy into that treatment plan, and this gets back to that partnership. I can't just tell them what I think is going to work for them. We have to come to it together, that they agree that this is something they want to work on. I also think it has to be in line with the cause of their pain, so it can't be something that's really directed at a nociceptive cause if there's a huge central component to it. And it has to work towards their functional goal. I think that what's been kind of disappointing to me as I've gone further and further into this is that the things that we are sort of taught in terms of this understanding of the new concepts of the physiology haven't always completely directly related to huge improvements in pain. So they haven't resulted in treatments that have necessarily gone so far as to sort of fix pain or really improve the pain. And it's really circled back to sort of some of those lifestyle management pieces. So I think we're still left with having to come at chronic pain from a multitude of directions. This is a conceptualization that I've thought about a lot in my integrative practice, which was when I was trying to get patients away from this idea that the medicine was the only thing that was going to help their pain, to thinking about all the other factors. I started to use this diagram, which was, well, we can talk about pain for a few minutes, but it's only pain medicine for a few minutes in this visit, but it's only one out of like 8 or 9 different things that we really need to touch on. And so getting the patient to focus in on other things was really helpful. So this is the way I think about approaching pain in primary care, and it's really starting at the bottom with lifestyle practices and then moving into more targeted therapies, and finally at the very, very top, just some meds and procedures in the patients who aren't responding to the other steps on the pyramid. So for me, at the very bottom, it's activity and movement, it's their emotional regulation and stress management, diet and sleep are kind of my 4 foundational things that I talk to almost every patient about. And then I start to layer in things like physical therapy if they need support in movement, or very targeted body-based therapies. It's behavioral and cognitive therapies. It's then some of those integrative therapies that I think actually have a ton of promise and a lot of evidence starting to accumulate around how helpful they are. And then only finally at the very top is it medicines and some of those adjunct things that we historically used way more, I think. So when I think about what actually works in my practice, it's really largely lifestyle changes and a lot of behavioral strategies, and then maybe some targeted medications when I think they're really appropriate or when someone is really flared up with their nervous system. Those can be really helpful in calming that down so that they can get to those other components. And I think really to get there, we have to get a lot of buy-in from our patients. So to get that, I think a lot about how I communicate with my patients, and this is probably in primary care the thing I spend the most energy on. So I think about how we can use empathy, education with our patients, and then how can we empower them to really make those lifestyle changes. So for me, communication with empathy is probably at the heart of what I do. I spend a lot of time listening to my patients and really making sure they feel that I've heard their whole story around their pain. Because if they don't, then it's going to be hard to get their buy-in that I'm on the same page as them and really we are sharing a reality around what's causing their pain. I throw in this kind of older study because I think to me it's like one of my best examples of highlighting why this relationship is so important. So they did this study on imipramine, one of the older tricyclic antidepressants. This was done in depression, but I think it holds across multiple areas. So they looked at, was this drug effective? And it was this drug and therapy versus placebo. And the drug was found to be effective in lowering rates of depression. But then they pulled out, did you think you got a good therapist or a so-so okay therapist? And they actually found the effect size from having a good therapist with placebo was more than if you had a bad therapist and the drug. So I think the good therapist won out over placebo. And to me, that means we as clinicians have a ton of power and we need to use it. I think educating our patients around what causes their pain is hugely important. And I've come to realize that this is more than just offering them sort of the pathophysiology of centralized pain. What it really is for me is making sure that me and my patient are on the same page about what's happening with their pain. So when I think about educating them, it's educating them on what I think is causing their pain and making sure that they agree with me. If we can get to that, and it's not an easy sell by any means, this isn't something I do in one visit and then it sticks, and then it's mostly I start the conversation in one visit and then the next visit they tell me what they remember and what struck them. And over the course of multiple visits and continuity, we develop a shared understanding of their pain. And in mixed pain states, I just find this is really complex and patients constantly go back to, but I think something's really wrong here. And if you don't fix it, I'm gonna hurt myself with what you're suggesting, like exercise. So I think it's just this ongoing conversation that's hugely important. I think our communication has to be realistic and hopeful, and this is what I was saying about setting up that framework to work together. When I get to empowerment, I have to recognize that there are a lot of barriers to empowering our patient. A huge amount of science is being done on behavior change and how we support patients to make those lifestyle changes. And so we could spend a whole conference on that. I think there are many of these barriers we can't actually impact, but there are a few that we can, like trying to shift the locus of control to the patient and getting them to have increased self-efficacy. And also treating any co-occurring mood disorders so that we can improve their ability to make these changes. I think that bringing the framework of motivational interviewing, I'm starting to think about chronic pain as just another chronic condition, like diabetes, like hypertension. If we bring the same models and framework to getting them to make the lifestyle changes we know support those conditions, we are also going to support them in feeling better with their chronic pain. So I'm not going to spend a ton of time on the lifestyle changes because other people are going to talk about those, but I just want to highlight that the ones I spend the most time on in primary care practice is increasing their physical activity, improving their sleep, and then offering them some psychological interventions targeting their mood, emotional regulation, and then cognitive reframing around their pain. This is probably like my slide of my most useful interventions, and I just bring these back around over and over and over again in the primary care space. So like I said, physical activity, we all know it has a lot of evidence. Really what I lean on is how can I get the patient doing more of what they're not doing? It's actually a really small percentage of my patients with pain who already have a really robust movement program, and I don't need to impact that. It's a much higher percentage that I have to actually just get started on movement in some way. So patient initiated, sometimes diagnosis dependent, those are the places where I start. Sleep, we know that's super important, so I won't spend a ton of time on that. And then you're gonna get some great lectures on nutrition and diet later, so I'm also not gonna spend a ton of time on that. So just to circle back to this idea that coming at a patient in primary care from my perspective includes these pieces, really focusing in on the doctor-patient relationship, making sure I have a really good, solid understanding of the cause of their pain, and making sure me and the patient are on the same page, making sure our goals are something that is really specific to my patient and that they buy in about, and then that helps create this multifaceted treatment plan that they can really buy into. And then I think that plan has to encompass all of these pieces in a stepwise fashion. So that's really what I have. I have no idea what my timing is, but maybe there's a few minutes for questions.